Well, welcome to the end of the day. Congratulations on making it to this. Thank you for staying till the end. My name's Mark Pasanen. I work at the College of Medicine. I'm a general internist by trade. I'm a very old-fashioned academic doc. I do both outpatient and inpatient medicine still. And I run our internal medicine residency. And I got very interested in opiates, which have become such a big thing to talk about, in 2009. In 2009, I went to New Zealand for one of these. In the last session, if you were here, talking about taking breaks, I did a reset and went to New Zealand to work for 7 months, work in a different system, take my family somewhere different. And what was amazing to me there was that there were no patients being treated with opiates, essentially, outside of cancer patients. And even in those patients, it was much different. I came back to my first day in outpatient practice, and on a day, I think, of 18 patients, not too bad, I think there were 7 that were on chronic opiates in my first day back. And it was just a moment of reflection of what the differences were culturally and what we were trying to accomplish. And I got very interested in opiates and how opiates were being managed into practice, and that's where I got started with it. And then over the last few years, I've had the chance to work with the state and talk around the state and in New Hampshire around how we might do this better. It's gotten very legislated and very overseen. And in fact, part of my message starting back 4 or 5 years ago was trying to stay out in front of the curve of legislation. We'd seen a lot more legislation around the country where non-medical folks were deciding how we would care for patients. And that concerned me that if we didn't get our house in order and start doing some things in a more consistent way, in a safer way for patients, we were probably going to get a lot of rules. And in fact, that's been the trajectory since. So this looks like a lot. A couple of these are very quick things. But we have an hour for this session, and I hope to finish up a little bit before that. Feel free to interrupt along the way. Oh, you're supposed to turn your phones to vibrate or off, I forgot to say. I'm looking at my host who's giving me the evil glare. So this is what I'd like to try to cover today, and that is we're going to talk about opiate, specifically opiate. We're not going to talk about all pain management for cancer patients. We're going to focus on some specific pieces around cancer care. We will talk about how useful that is, and as you can see from the list up here, we're going to try to talk about how we can do this safer, more consistent. Interestingly enough, when I first started talking around the state, cancer patients had a buy on all this. And it was sort of like all my talks were around non-cancer pain. And as time went on, people started to look more carefully at the prescribing that was coming out of different populations, outside of probably the very end-of-life palliative, end-of-life care piece, I should say. But people started to look more carefully. And in fact, when you start looking more carefully, you find a little more trouble than you thought. I'll also talk a little bit about how I think you can make life easier around opiate prescribing, because that was one of the things when I went around the state. We didn't just talk to docs, we talked to office staffs. And interestingly enough, every office staff, either the docs thought everything was awesome and the staff thought it was a disaster, or vice versa, because the docs could put a lot of the work on staff and have them deal with all the calls of early fills and different days and tell them they couldn't get refills and all these kinds of things. And it was working fine for the doc, but the staff were losing their mind. So we're going to try to cover a bunch of this. Well, I don't need to tell anyone that some of the very basic demographics about this, but pain and cancer go together quite commonly, really commonly. So during treatment, as many as a half of people will be experiencing significant pain. And in a more advanced state, it's the vast majority. And even after people have had successful treatment, pain continues to be a really common part of their regimen. So we're talking about before, during diagnosis, during treatment, and after. It's really something that we've got to manage long term. And it can be directly from neoplasm. That's probably about 3/4 of the cases. But like I say, 1/4 of the cases are going to be late effect, other related to treatments, or other things that came along during the treatment. And if you take a specific group and you say how common, for instance, is pain around someone who has surgery for breast cancer, it turns out it's really common, and there's some things that might help you predict who has the most severe pain. So 400 patients who were recruited prior to surgery, followed over 6 months, looking back at how they managed. About a third had no pain syndrome at all before that. About 40% had mild pain, and 1/4 had moderate to severe pain going into surgery. After surgery. And of those people, the people who had pain before surgery, who had decreased arm function, all these things you can see on here were all predictors that they would have more pain afterwards. I don't think there's probably any big shockers on that list, but it's just something to be thinking about when we're kind of thinking, unfortunately I think we think that we're going to do something curative and we'll be past the pain. One of the big struggles of treating chronic pain, and everybody knows that, is really moving past when that's going to go away and how we manage with that pain. And that's a ginormous step for us to take. It deals with hope and all these things that start to be complicated. But these are some of the things that gave predictions. And it just reminds us how common it is. There are lots of treatments. So, in talking about opiates, I feel embarrassed that there's this giant world of treating pain in cancer patients. I'm covering just a tiny bit of it. Part of that's because it's a really important part and it's really messy. But there's all kinds of things from pharmacologic to different interventions. There's so many integrative ways and a lot of the things that people have heard about today, psychological, stimulation, rehab. There's lots of modalities. So I just wanted to remind myself that we're talking about a narrow subgroup of the treatment. And people have talked about treating opiates, using opiates for cancer pain for a long time. This is the World Health Organization. We go back to 1986. And they actually basically were the first people to come up with this pain ladder around cancer pain patients. And this is where it started. And it was shortly thereafter in the United States we started to have more access to long-acting opiates without acetaminophen in it. And we started to see a real increase in the amount of opiates used. But you can see, I don't think this is anything that anyone would be surprised at, but it goes back a long ways now. And really the balance has been between undertreatment, which is a huge problem, and overtreatment, which people early on said you can't really do, and then people started to realize actually overtreatment is one of the problems we've got to worry about as well. Undertreatment is probably a little less common if you look at the big reviews as far as over the last 15 years. Used to be as in the 40 percentile people said were undertreated for their pain. It's now closer to 30% in most studies that look at pain. They look at big pain studies and see what percentage of people still have significant pain in them. So we're down to about 30% of people, but that's an awful lot that are undertreated. And what are the barriers? Well, I think it's gotten worse and worse because, now we have, before we were worried about lots of things. I have a slide about what we worry about, but now we have sort of logistic hurdles as well. So I worry, although the movement has been to less undertreatment, that the sort of stigma of opiates out there and the complicated nature of prescribing these and all that kind of stuff that's out there in the press is actually going to potentially be a barrier to us to continue to do a decent job about treating folks. Before I get too far in, we're going to cover some things. These are just some very basic definitions. You probably know most of these things. Maybe a couple at the bottom aren't quite as familiar to folks. But when we're talking about chronic pain, we're talking about pain lasting at least 3 months. Long-term opiate use would be at least 90 days now. It says 3 to 6 months, but almost everyone's defined that as 90 days now. That's long-term opiate use. This is not years. We're talking about months now. Tolerance is the need to take more for an adequate effect. Dependence is withdrawing when we take it away. And addiction is really a very different thing, right? This is compulsive use, use in the face of harm, and not having a controlled use. It seems a lot like this thing that's pseudo-addiction. And everybody who prescribes opiates has seen pseudo-addiction, I'm sure. And that is someone who's really got a very set idea of how they want to manage their pain, right? They know what medicine they want. They know this one works better than that one. They're very focused on it. They're very focused on the dosing. They're very focused that I want to make sure my scripts don't get screwed up. That isn't necessary. None of that's addiction. Some of that's just this is the one thing that keeps them okay at times. And if they don't have it, life is really bad. And they behave like that. And that's not addiction. And unfortunately, that gets pigeonholed into, this is a drug-seeking patient, a high user. They asked for Vicodin by name. That's just, walk away kind of stuff. It just isn't supported in the data, in the literature, really. And then there's this idea of pseudo-opioid resistance. That's a little bit of a funnier one. That's people who are actually doing okay, but they're afraid to tell you they're okay because you might do two things. You might stop trying to figure out what's wrong with them, and they're very worried about that. And two, you might say, maybe you don't need this anymore. Maybe we should start dialing this back. So there's actually a group out there who are acting uncontrolled, who are reasonably controlled, and somehow we have to get at that with those patients. Okay. Not very complicated, once again, just kind of gets us on a same footing. what we're trying to do when we use opiates is very simple, three super important but simple things, and we shouldn't forget it. We're not treating a disease state. We're not changing a prognosis of an underlying disorder. We are making pain better. We are very importantly trying to change function and quality. Those are probably things that we've been less good about evaluating the efficacy of our treatments when we started to put a number to pain. Right? When we started to put a number or a certain smiley or grumpy face for pain, we started to be very objective and talked about, geez, someone's still 10 out of 10, 10 out of 10, 10 out of 10, it's not working. But if they were now being able to work, sleep through the night, have sex, whatever it is that the pain was preventing them from doing, we might have made a major change, and we got to be a little careful not to get too hung up on just numbers. But we've learned more and more about the risks of time gone on, and everyone is familiar with these, and I think everybody, who pays attention to the world is knowing these things. There are toxicities. There are people who function less well on opiates, and there are people who have this opioid-induced analgesia now, and they start to hurt more in the face of opiates, and that's a tricky thing. I don't think most of us believed that back in the 80s when we started prescribing opiates in the early 90s for chronic pain, but we've now seen that, time and time again, that there's a subgroup that's pain will escalate. We'll talk about that a little bit at the end. And, of course, we're worried about the misuse piece. Okay, so the American Pain Society has an incredibly vague guideline about who should be on opiates. And so I'm just going to go through that real quick. This is for anybody with pain. And it's moderate to severe pain where there's an effect on function. You're pretty sure the benefits are outweighing the risks. And they somewhat hedge on whether we should screen for folks. So I'm going to touch on that in a sec. But pretty vague, right? You think it's a good idea. That was their sort of take-home. So how well do opiates work for pain? This has actually been a challenge because most of the studies are short and they're small, and they often compare opiate to opiate. And if they can be about as good as the other opiate, that's kind of good enough. They don't really have to prove that they're better than placebo. So it hasn't been really, considering how common pain, whether it's in cancer patients or in non-cancer patients is, the science hasn't been fantastic about doing this in a really robust way. So in this trial that looked at a review of randomized trials of how good opiates are in cancer pain, they point out there are a lot of people living with cancer. Opiates are an important part of the treatment. We're more worried about it, and we should better understand what we're getting for these risks, right? That was what they wanted us to focus on. And so this review looked at it and basically came away saying we tried to look at pain relief, quality of life, and how many people had side effects. It's really hard in those trials to figure out how many people are misusing. That's always been a bugaboo to try to capture. They're very controlled populations. And what they found is that there was probably reasonably fair evidence that transdermal fentanyl was effective for pain and lower quality evidence about any of the other opiates we use regularly. But if you look at the data, pain scores do drop. They're just often not considered high quality evidence because they're comparing oxycodone to morphine, and they both drop about the same, and so they don't love that kind of science. So I think we've all seen that. People's pain often improves, sometimes doesn't. We'll kind of go through what to do when those things happen. And this was actually just using specifically oral morphine for cancer pain. And in fact, what you can say is they decided almost 2/3 of the patients were a treatment success, depending on how you define that. And if you define that as sort of the patient's happier in that state than the other state, you had pretty good results of treatment success. They didn't see any differences between sustained release and short-acting formulations. In fact, very rarely do people find consistent differences between short-acting and long-acting. And we'll talk about that in a sec. And the dosing that they saw in these studies was an average dosing of somewhere between 100 and 250 milligrams of morphine with a high of about 2 grams of morphine. Just to give you some idea, we'll talk about dosing in a little bit. They didn't have too many people stop because of adverse effects, and that's about what I think people see in practice. So when you get into the specific opiates, and is there a difference, the short answer, if you don't want to pay attention to the next 2 slides, is it is really hard to convince yourself one opiate's better than another opiate. And so to some degree, I think you get comfortable with what you get comfortable with, so you're familiar with the dosing, and, stick with that. That's my advice. I use lots of morphine. When I went into practice, oxycodone got a bad name. I was pretty familiar with morphine, and I've used a lot of morphine over the years. And we'll talk about why I might switch, but I still think that's, nothing wrong with that. It comes in every possible formulation other than transdermal. And we have the sprinkling long-acting versions now that you could use if that's something that you're trying to do. Fentanyl is probably the only thing is when you look carefully, it is probably a little less constipating than morphine or the other opiates. It's only been compared to morphine. So when we talk about how one might manage constipation from opiates, one of the strategies is to think about changing from morphine to fentanyl. Doesn't work for everyone. It's not great when it's 93 degrees out and humid in northern Vermont. We'll talk about some other limitations to fentanyl. But it is less constipating, at least we think it is, best you can tell from the data. It doesn't work great if there's no fat. It actually gets pulled into the fat and gradually absorbs. So if there's no fat where the patch is, there's no fat on the body, fentanyl patch isn't going to work as well. So that's a limitation. It's certainly a limitation, and people have more advanced cancer. It has metal in it. People are starting to know this now. You can't go in an MRI scanner with a fentanyl patch on, or actually AVMMC now they screen to make sure people don't have a patch on. So it can't do that. It's got little tiny bits of metal in it. There's a whole bunch of fentanyls. I have not used any of the rapid-acting fentanyls. They're all, you have to be certified, take your class, become REM certified through it. But it does exist in lozenges. There's transmucosal tablets, this effervescent tablet you put in that dissolves, film, spray. I mean, it comes in a lot of ways. You can't prescribe any of those unless you've gone through the work of prescribing those specific things. What about codeine? Codeine should just probably go away, would be my take on it. I don't think there's really a role for using codeine. In 1986, it was on the second step of the WHO. Codeine's tricky. And the funny thing about codeine is it's got this significant chunk of people who metabolize it funny. So if you've not heard that before, there's a group of folks who are very slow metabolizers. The codeine has to turn into morphine to work. So if you're very slow metabolizer, so you start taking it and it just doesn't happen, you don't get morphine out of it. And so 5 to 10% of those folks will have a very limited effect from codeine. Probably the worst of those two problems is there's a subgroup of people who are very rapid metabolizers of codeine, and they actually developed a lot of morphine very quickly if they're taking decent doses of it, and they'll actually morphine overdose more quickly. Not a huge problem because we don't have a ton of codeine used anymore, but nevertheless, I'm not sure there's a great role for codeine in long-term management of chronic pain. It's just a little bit messier that way. Methadone, are people methadone? Do people prescribe methadone for pain much? Yes, no? I used to, now I don't. I grew up on methadone. That was my residency opiate of choice for everything. Cancer, pain, whatever it was, we took it in a bottle, and we made how much ever methadone, acetaminophen, and Phenergan you wanted in a tablespoon. And people just took that tablespoon 4 times a day. You couldn't sell it. You could put in it whatever you wanted it. You could put some Tylenol in there if you didn't want people to drink the whole bottle. I came to Vermont in 1996. I came back to Vermont. And I said, you guys use methadone for pain? And everyone looked like I was a crazy person. There was essentially no methadone being used for pain. And then it became super popular. I'm on the Medicaid Drug Utilization Review Board. We made you jump through methadone for a while to get to other opiates even. And we backed off on all that. Methadone, as everyone has learned over time, is a pretty tricky drug to use. It's tricky for a variety of ways. Probably one of the most tricky things about it is it has incredibly variable metabolism. And it can be anything from hours to several days as a half-life, making your ability to convert. And so what we know is if you're using methadone, you shouldn't be changing dose before 2 weeks have gone by. This is not one of these medicines where you're like, try this and tomorrow take twice if it didn't work and take it quicker the other day. I mean, you stick to a dose and you stay with it for at least 2 weeks because you have no idea if it's building up steam. It has certainly, the advance of using methadone has led to significant higher problems with overdose, partly because of the metabolism. And I think everyone knows the QTC. The QTC is not a huge thing, I'll mind you, on the doses that people tend to use for pain. A bit more of a problem for the higher doses people tend to use for opiate dependence. Remember, those people are taking 100+ milligrams of morphine a day often for opiate dependence, not usually being used at that kind of dose for other pains. It is interesting. It's a different medicine. It doesn't have quite the same euphoria. It has some neuropathic stuff. It's got some cool properties if you're a pain geek. But as far as its use in the real world, it's been a pretty tricky drug to use. So just a few slides on the logistics of what the state expects. And there's really 2 documents. If you've never seen and you're prescribing opiates, you should glance at least once in your life. One is from the Vermont Board of Medical Practice. They updated their substance, their their controlled substance recommendations in April of last year. And then just recently, the Department of Health has updated their prescription monitoring system requirements and their opiates as of August. So they just did that. I'll cover that in a second. So these guidelines just are very consistent and acknowledge that there's a lot of opiates being used and a lot more problems, and we're a little bit worried that there isn't the greatest evidence base that we're doing good stuff. So they got very picky, and they said this, and I think this is all reasonable. It just looks terrible when you have it on a slide of, it's one of those things, there's 4 million things you're supposed to do, and you're actually supposed to be listening to people and taking care of them. Some of the stress we heard about managing a life in a 15-minute visit. And it just said you have to have a patient-physician relationship. There has to be judgment in there. You have to be going through what they think is best practice. They sort of hedge on that a little bit. You have to document. And I think this was the important big change in it. They want us to prove that there's demonstrable benefit. And what does that mean? Well, I don't know, if you've been doing this a little while like I did, here's how opiates worked for me my first 5-6 years of practice, maybe longer than that, maybe before I went to New Zealand. And what I did then is I kind of get people on opiates, and essentially if they said it wasn't too bad and they didn't screw up, they got opiates forever. Like there was just no stopping it. Like I didn't really know if it worked. They didn't seem to be complaining. They said things were a little bit better, but they never left their home. They didn't have any obvious benefit from a function. They told me everything was awful and miserable, but not to take the opiates away. And I didn't. So that's kind of what I did for a long, long time. And I went away, and you start to think about this. You're like, okay, that's sort of like we talk about this, kind of like putting people on blood pressure medicines, and they come back and nothing happens to their blood pressure. And say, might as well just keep taking it. It's not doing anything, but might as well take it because, and you sort of shrug your shoulders. So that's the big change, I think, in the guidelines have been, okay, prove to me this is improving pain, function, quality of life. Put it on paper. And don't just show that they haven't messed up. There's another step to that. And, of course, everybody knows our ability to measure function is not great, right? So that's a big challenge for us. What is function? Touch on that for 2 seconds. There were a lot of factors that they identified this is from the practice board, why people prescribe inappropriately. And, by the way, inappropriate prescribing can be under or over prescribing. It isn't the definition. We all worry about over prescribing, but it's under prescribing as well. And this is a list, and I don't think probably need to read them all, but it essentially gets at many of the issues that made us make mistakes, from everything practicing way outside of conduct. That's no one here, right? That's just there. You look at the way some people are using opiates in the state, and you find some patterns that are concerning around individual use patterns. But most of it, I'm working backwards here for no real reason. Closer to me. Fear of causing addiction, or that's become a big thing, right? I'm going to turn people into addicts. I don't understand dependence and addiction. I'm sort of lost in this whole thing. It's another one is not having set appropriate goals, right? If the goal is pain eradication, you're doomed, right? You're doomed because there's really none of these treatments, opiates or anything, that's really leading to permanent pain eradication as a regular thing. If that's your goal, you've set an inappropriate goal. I remember when I first came to town, actually, it was amazing. This is not a cancer pain patient, but one of my colleagues asked me to see someone because their therapeutic relationship was strained around the use of opiates. That was the expression. And I picked this person up, and I said, okay, well, I'll see anybody. That's fine. And she was on, I remember perfect. She was on 1,200 milligrams of morphine a day and 120 milligrams of hydromorphone a day. So a relatively respectable dose of opiate. And the sign had been she's on a fair bit of opiate, and her pain's not controlled. And this is sort of what was happening back then, right? It was never-ending escalation of pain meds without clear benefit. She was almost asleep when I met her. She could, this was a doc that I respected, but it was amazing to me. And it's like, at some point, we needed to have given up on that as a treatment arm, and we just hadn't. And it was just going to keep going till the pharmacies ran out of medicine. She was getting 900 Dilaudid tablets a month, 4 milligram Dilaudid a month. And, that may not be that may be appropriate in some patients. But in this patient, this was really not offering benefit. So, I think there are a lot of worries that people have. And we don't know much about pain. And you have guidelines that say things like, try to do the right thing. Our guidelines, don't pick a drug, don't pick a dosing formulation, don't pick a don't tell you exactly what you should do for screening, et cetera, et cetera. So they're pretty vague, and so I don't blame us for not knowing what we're doing. About medical practice, this is all things that people have seen probably at some point, but just glance at this. This is what's expected in your documentation for anyone who's getting chronic opiate therapy. Actually, any controlled substance, to be honest. So it's evaluation that you've risk stratified their likelihood. We'll talk about that in a sec. You've developed a treatment plan. You have defined the goals of that treatment. That you have informed consent and treatment agreement. Those are two different things. Informed consent is really the idea that they understand that opiates have risk and that taking them has risk. Treatment agreement is the logistics of we don't fill these on the weekend. If you lose your pills, we don't fill them, et cetera, et cetera. There is no mandate for periodic drug testing right now in this state. There are in other states. That we respond to aberrant behavior, that we don't just, wash away the urine toxins that are funny, et cetera, et cetera. So a lot of rules. So we'll step back and say, okay, well, we're seeing someone and we're actually at that point in time where we think that opiates are our next step, having gone through the steps of things. And so this is one of the things that's very confusing, is that really there has not been consistent data about the difference between any of the opiates, as I already mentioned. There are not any data. You'll find a study. Someone can pull up a study of oxycodone ER a little better than IR in a subgroup of people, but it just isn't consistent. And really, no one's come up with the right starting doses of things. So people have been very much on their own on these things. What has become a little clearer is that everyone is expecting us, and it's in the literature now, that we've done, in the legislation, that we are actually documenting how we're screening for the potential of abuse. It doesn't have to be a million things. But I think everyone expects that we're screening for at least these three things. That we have in the chart, not we did it, I promise, I do it every time. I always ask those questions. That doesn't turn out to count when you ask the practice board. Actually, the practice board, when they look at who they investigate, they often, the cases that they find hardest, they can't figure out what the pain is that's being treated because people have just started writing chronic pain, not done an exam, and they look back for years, and it's now not even clear what the pain syndrome is. They don't love that at all. They tolerate the exam piece, not having the exam, but they don't love not being able to identify what the pain is. So depression, substance abuse, and misuse, I think those are the bare minimums actually in the lay of the August 15 recommendations. So depression can be simple, doesn't define what you have to do, but you better screen for depression. It can include, are you depressed? That would be fine. This is the most common. So PHQ-2, people may know the PHQ-9, a bigger one. If either of these were positive, that's have you been bothered by feeling down or depressed in the last month? Have been bothered by interest or pleasure in the last month? Those would be screens, and you'd be a bigger one. You could do a bigger screen for depression or identify depression. This is just, there are a million different, everyone probably has some way they screen for alcohol or other drugs. This is the Audit C, a very simple one. Catches about 85% of men and women who are overusing alcohol. Like I say, I realize the time I don't act like this is easy, but just as an FYI, they're expecting that we've at least put something down. Would it count to say I screened and I think they're at low risk of alcohol? It might. They don't define that, but I think that just not asking some of these questions is a challenge. And then the risk factors for misuse are these are the ones that have been identified. It's the younger you are, personal or family history of substance abuse, mental health problems, a history of legal issues, or a history of being abused are all predictors. And I'm not going to belabor this a lot. I'm just going to show you two screening tools that are out there. I don't know, are people familiar with either the SOAPP or the ORT? So these are both validated tools to some degree that are relatively short that you can fill out. And this is actually a screen, once again. I'll flip to the next one. This is the same slide just with the data. But it basically just tells you how likely someone is to misuse the drug going forward if they screen positive. So this is positive predictive value. That means that if you have a score of 4 or more of that, there's about a 70% chance you're going to misuse that drug going forward. This is not cancer patients. I'll show you cancer patients in a moment. But it's just a tool that's out there that some people have standardized starting to do. And in fact, people can fill that out themselves. And as we someday have patients with tablets in the waiting room, or those of you who have that, these are the kind of things we're probably going to have people filling out. But what about in cancer patients? Well, they looked at about 500 patients in a clinic that was following patients with cancer and pain. They screened with the SOAPP, and about 30% had some high risk, and that was mostly depression and anxiety. So I'm not sure it's capturing quite right in the cancer patient population, in all honesty. I'd be pretty worried about that, but that's just, an interesting thing to see. The more pain you had, the more opiates you're on, and the more depressed and anxious you were on, the more likely you were to flag on that test. We still don't know what that means, but that's what they found when they started looking. Is anyone familiar with the opioid risk tool? This is another screening tool, just real quick. This is what Washington State, when they legislated the use of opiates in Washington State, they chose this tool and basically had you defined as a low risk, a medium risk, or high risk group. If you were a low risk group, the recommendations were you actually had to have urine tox testing at least annually, and if you were high risk, it was quarterly. And so that, once again, was in a broad population of patients with pain. And it's the very similar questions that we just asked, just as a reference. And once again, when they looked at the ORT in cancer patients specifically, once again, they still found about a quarter of the patients flagged as high risk for opiate misuse on the ORT. So I think all that tells us is we just have to be aware that it's not 0% and that there's some risk of misuse, and that as much as we don't want to go there with that patient population at times, we're probably not doing a perfect service if we imagine it could never happen. We don't have great data about how often those patients are misusing. These are, in the long run, these are predictors by a tool that says they flagged as high risk. And if you look at in a palliative care clinic, like once again, lots of people with high scores. So, and in that group that was high risk, they found aberrant results. So there was some misuse being used out there. I don't want to belabor that point, but just I think it's informationally important to be aware that it's not impossible. And of course, and there people have different things. So a quarter of people using cocaine that flag positive, people may have a different opinion about that than, say, the use of marijuana. And I'll talk about negative for opiates in a second, because urine tox screens are one of the frequently misused tests out there. So the checklist, I think, when we're starting opiates, whether it's a cancer patient or non-cancer patient, includes that we should be screening for depression, substance use. We should be considering the use of some kind of standardized screen. That's what it says, consider using a standardized screening test. And they quote the SOAPP or the ORT in the recommendations. We'll talk about the VPS in a sec. And that's sort of the basics of starting. I mentioned before, I think it's really important to set realistic goals and describe starting an opiate as a trial of a medication. It's not a permanent decision. If this is effective for you and your pain and your quality of life, and you function better, then this is a great treatment. If we're not seeing those things, this is a very high-risk group of medicines, and we shouldn't keep doing them because there's risk to you of increased pain, of side effects from the medicines. We shouldn't keep doing it just because we started it. The practice board mentioned already the informed consent, and I'm going to kind of skip that for the sake of time, and some of the similar things that are in the treatment agreement, some of the things I mentioned as well. As far as prescribing, how many people are 28-day or 7-day cycle prescribers? So if you're a prescriber of opiates, I'd encourage that, whether it's for cancer or not cancer. If someone's on a stable dose of opiates, the 28 things in 28-day lots just work for offices better. You don't end up with Saturday and Sunday refills like a 30-day does, right? 30-day fills just hits that date, and then someone moves it to Friday, or Sunday they move it to Friday, and it gets off. If you're on a 28-day cycle and you gave that person that prescription on Tuesday, they are due for it 4 Tuesdays from now. And they pick it up, and they don't start. Has this ever happened to you? I'm sounding like people are, there's 28 days in February, Mark, right? You know that, right? Because, and I said, yeah, no. And you get away from all that in 28 days. Like, it should be, it's not the 30th anymore, And you just get away from that kind of conversation, which I had like a bazillion times in my life. So when we went to 28 days, which was a huge thing, the other thing about it is if you're not in the office every day, it turns out the people you work with don't find it awesome to write your opiate prescriptions for you. They don't go like, oh, good, they're not here. Where's the opiate prescriptions? Let me get those done for you. So it just gets away from that. So if there's a day, you can say like, hey, Tuesdays and Thursdays are my opiate refill days or whatever. Those are the days I'm there. You can just standardize it. You don't have to count days. The other thing you can do, and it's legal, is you can write those scripts. You can't post-date a script. So if you're in written script bill, you can't post-date it. But you can write it for today to be filled as far as 90 days out, well, really 56 days out. So if I'm seeing someone stable on opiates, I write the prescription today. I write a prescription for 20, that's dated today, that's not to be filled for 28 days. I write another one not to be filled for 56 days. And they get those 3 scripts. Those 3 scripts, they have 3 choices to do with them. They can take them all home, they can take them all to a pharmacy, or they can leave 2 of them with me and take the one that's due most recently. I strongly discourage them from taking it home. I say once they're out of my office, they're out of my office. Like they're like filled scripts to me. And so if you lose those scripts, they get wrecked. We're not going to fill them. In our system, it looks like it's a done deal. It's too much work. So most people either, if a pharmacy will let them stay, not every pharmacy will let them do that, but a lot of pharmacies will let them do that. It lets them predict when they don't love to have a room full of OxyContin in the back, of sustained-release oxycodone. So they like being able to predict when people are going to need their medicines. So some places like that, or they just up front at our office, and there's no phone call. They know it's 4 Tuesdays from now. They stop by and pick it up when it's due. It's in a little envelope. They show their ID. They leave. There's no paper trail of did you fill the script? They're due. It takes 2 seconds to do. So if you're not doing that, it's just an easy thing, to be honest. And it's fine to do. You won't get in trouble doing that. I mentioned that a little bit. The diagnostic plans is another thing to mention. And here's how the VPMS. So I don't know if people have read the new. Has everyone been on the new VPMS site yet? Those people who are prescribers, anyways. What do you think so far? Yeah, it's not quite perfect yet, that's for sure. Probably the big thing is they tell us pretty soon, and it might be by now, but I'm guessing this was about 2 weeks ago. I heard in about 2 weeks, so I'm guessing not yet. That's just my guess. Is you'd be able to get delegates. We weren't able to get delegates onto the VPMS for a long time. This system will allow people in your office to do VPMS searches for you. That was the original plan, but they didn't have the bandwidth with the old program. But interesting enough, in August, they actually took cancer pain for this is the first time I've seen something at the state level differentiate cancer from non-cancer pain. And the state specifically says you're not required to use VPMS for cancer-related pain. So that's new language. I hadn't noticed that until I read it at the end of August. So that's kind of a new thing. I'm not sure I'd get in the mode of not looking at VPMS a lot and differentiating that if you're treating different kinds of patient populations like I do. It's almost harder to remember who does something one way and another way. And especially if you're allowed to have delegates, I think that could be helpful for folks. But here's what the new rules are as of August, if you hadn't seen them. The first time a provider prescribes an opiate to treat chronic pain, you have something that you're defining of 7 years of back pain and you decide to try an opiate that day, you're required to look at VPMS. Once again, if it was cancer-related pain, I'm going to just imagine those are different. You have to do it at least annually for ongoing treatment. You have to, anytime you're starting a non-palliative opiate, they actually wrote that in the language this time, it wasn't there previously, that you're expecting to use for more than 90 days. Once again, you need to check any replacement prescription. I think people know that one. Oops, that's in there twice, sorry about that. And when prescribing for acute pain for more than 21 days, that's a new thing. So if you're going to do more than a 21-day trial of medicines for an acute pain, a fracture, before they keep getting refills, they're going to require us to do a VPMS. They haven't figured out how they're going to enforce that yet. So, and they actually point out that they want us to be doing the 5 A's. For those of you on an EMR, I have a little template that's my 5 A's for everyone with chronic pain, where I talk about the analgesia effect, how it's affected their function, whether there are any adverse effects, but then there's evidence of aberrant use, and how their affect is. Those are the 5 A's. Sometimes it's 4 A's. Affect is the 5th A of how their mood's holding up. So they expect those to be documented regularly in the chart. There are a couple of functional assessments. You can use a lot of different tools. There are specific arthritis tools. There are specific back pain tools. There isn't a specific cancer pain tool that's been super validated. These are just some of the ways people are trying to put a number on function and sort of saying from 0 to 10, how was your pain? How's your enjoyment? How's your activity, right? Those are the 3 things we are supposed to be measuring. And then people have turned that into big, long things like the PADT. That is a paper format that people have tried. And it just gets at all these things, right? Just if you're not sure what to ask, it's a little checklist of the adverse effects and the, list of aberrant behavior. It's merely a reminder, as EMRs get better and better, hopefully one of these days, we'll see some of these things being a bit easier to use, I think. I'm not a big fan. Does anyone use the COM? Has anyone ever heard that? That's actually an ongoing tool. It's mentioned in the literature as well, in the legislative stuff as well. But it's just a way to find people who are at risk for misusing while they're on treatment. So it's current opiate misuse measure. And I'm not a huge fan of it. It's pretty long, 17 questions. But it has a lot of questions like, is there anger and worry about your meds? Have you seen other medicines? Have you been to the ED? It has a bunch of that stuff in it. I'm not supporting doing that, but you'll hear people talk about it who are really into this. Urine testing. Does everyone feel awesomely comfortable with their urine testing for opiate use? Because it's pretty complicated, right? And so all of a sudden we just started doing tons of urine opiate tests. I was talking up in the northern part of the state, and actually one of the staff said, yeah, no, I just opiate tested my son. It was almost $1,100 for that test. That looked for absolutely everything one could possibly look for. We actually don't have a perfect test, I think, at UVMMC. We're working on trying to have a better panel. We have a Urine Tox 6, which is your classic opiate, cocaine, barbiturate, marijuana, cocaine. I end up, the list ends up, there are 6 things on it. But benzos, opiates, cocaine, amphetamines, phenobarbital, and marijuana, those 6 things. But it turns out that doesn't pick up things like fentanyl or oxycodone or methadone, for that matter. Right? It's not designed to do that. So I'm going to show you something about that in a second. There isn't a standard as how often this should be checked. This is just one of the tools in your toolkit to decide how you want to use. But I think people misuse it a lot, and I think, we had early in the day, we had people we kicked off of opiates because of failed urine tests, not just because we didn't know how to interpret the test. There are really 3 broad classes. This is oversimplification, but there are the naturally occurring opiates. That's pretty much morphine and codeine. There are the fully synthetic drugs like fentanyl, methadone on the right there, and then there are these ones in the middle. And so if you look at the urine tox screens are just looking for pure opiates. If you have enough of them, they'll sometimes start showing up. But a urine tox screen that is negative for opiates doesn't mean they're not taking oxycodone. You'd have to do an opiate, what we call at UVMMC, an opiate confirmation test. So here's how opiates are metabolized. This is another thing that confuses folks. Has anyone ever seen someone taking hydrocodone and they had hydromorphone in the urine tox test, right? And you say, oh, yeah, you're clearly using a lot. Well, that's actually what happens. Right? Hydrocodone turns into hydromorphone. That's how it works. Codeine, it's actually kind of easy. The C's all turn down. So codeine turns to morphine. Hydrocodone turns to hydromorphone. Oxycodone turns to oxymorphone. The nice thing is oxymorphone and hydromorphone don't have anything they turn into. So those should be clean urine toxins. And I will say you shouldn't have a little bit of oxycodone and a whole lot of oxymorphone. That's not how it works. You should have higher levels, but people are very careful about saying don't use the levels to determine what you do about care. But just be aware when you start looking and you say, okay, well, the opiate things, I better do this opiate confirmation test. That's what we do. And you start looking, we see this. And we had one of my residents the other day was like, oh, yep, they're taking hydromorphone. They're done. And it's like, yeah, that's what's supposed to be in there. And so I think it's just important to understand the limits of the tests and how the drugs get metabolized so that you're interpreting them right. There's also some false positive things. So probably one of the most famous ones is proton pump inhibitors will occasionally turn people positive for marijuana. So if you're one of those folks who if marijuana's in there, they're done. And when I've polled people around the state, it seems like about half the people care if marijuana is in the urine tox and half don't. The proton pump inhibitor is a drug that can do that. Interesting things like quinolones can trick for positive for opiates for a while after you take it as well. So there's just some little things like, it's not to memorize all that, but when you see a test and you're going to make a major decision based on it, you need to go back to this kind of stuff, look it up, go back to the metabolism. Talk to someone. I've talked to the lab at Mayo to say, I don't get this. And I've talked to the people there, the lab folks there. They're awesome when we don't know what to make of a particular test. So just be careful. They aren't fat. They're not this, and you took that, and that's what that is. They're more tricky than that. I mentioned the 28-day prescriptions and the increments of 7, so I won't go back on that. Is anyone a fan of opiate rotation, rotating opiates? So some people like that. They're not a great bout of data on that. I think if someone's having adverse effects, then there's something to it. There isn't really a set recommended rotation piece. Fentanyl actually has a fairly well-defined process. If you just look on, you can just look on their website. You can find it anywhere where they'll tell you if you're on this many oral morphine equivalents, you should be on this much fentanyl. So it's actually a straight transfer, and it tells you don't have to do any dose adjusting. It tells you what to do. For everything else, you have to basically reduce dose somewhat as you're switching just because of cross tolerance around it. So you're not going to want to give the exact dose. You're going to usually smudge that down about a quarter, about 25%, and pick the dose that's a little bit lower as you switch drug, because sometimes people will, and you may have to quickly come back up, but you wouldn't go as a straight swap. And for those of you who do methadone, it doesn't matter if someone's on 1,200 milligrams of 1,200 milligrams of morphine. The recommendation is don't ever switch to more than 30 milligrams of methadone a day. That's the highest first dose of methadone you'd ever give. I'd be nervous about that. And so some people have started to do morphine tapers or methadone starts. It can get super complicated. If you're doing methadone, just be really careful. And I don't think methadone is for everybody right now. I just think it's a tricky drug to use. Like I say, having used it a fair bit, I've used much less methadone now than I used to, which I kind of miss because I think it's kind of an interesting drug that way. But it is a multiple time a day drug, so it's not the most convenient thing in the world. So that's how, just be careful about those switches. And for those people who aren't used to doing oral equivalents, this just reminds you what they are. These, where if you look at like 10 of these lists, they all look a little bit different. So just take them with a grain of salt. But it just reminds you that oxycodone, hydrocodone, morphone all come out about the same milligram per milligram. That's about how those work. Hydromorphone is about 4 times stronger than morphine in the oral equivalent period. And so just remember a fentanyl patch is about, so if you're taking the very starter dose of a fentanyl patch, you're starting someone right off the bat on the equivalent of about 4 to 6 oxycodone, 5 milligram tablets a day. So if someone's completely opiate naive, be a little careful with the fentanyl patch because it's guaranteeing a set dosing right off the bat. The 12.5 is not so bad. I think you can sort of get away with that sometimes. But then when we used to only have the 25, that was too much to start someone on. That was a 8 to 10 sort of Percocet a day right from the get-go on someone who hadn't had any opiates. I wouldn't have recommended doing that. The 12.5 maybe. And like I say, methadone, just be super careful with. I'm not sure there's a pressing reason you have to use methadone. So I would move around trying to use other things before I used it. All right, so then we have a couple other things. I just want to cover some side effects and what to do about acute pain. What do we do in acute pain and someone's on chronic opiates? Well, we wonder why, right? So there's a couple of things like, is there something completely different going on? Have they developed a different problem? Has there been a progression of their underlying problem, particularly a problem in cancer patients? So things like spinal cord compression or a pathologic fracture, things that might not have taken the same amount of injury force that we would think of. Have they become tolerant? That will usually gradually sneak up on us so that they're tolerant. Have we done a drug that's changed the way they're metabolizing it? And, I think we're, in the next 10 years, we're going to get bludgeoned with SIP, the cytochrome 450 system kind of stuff. Because drugs like diltiazem, say, I just picked the most common one, fluconazole, all the azoles will do it. They're inhibitors. So if you add one of these drugs and someone's on an opiate, it'll actually decrease the metabolism of the drug, and it can lead to more drug being in the system. So we're going to start getting savvier about that. Hopefully computers will save us on this one, because these lists are super hard to manage. But just something to be aware of. If something changes in someone, just look back and see what's changed about them. So you're wondering, is it tolerance? Is it the pseudo-addiction, the piece that I said, like they're acting crazy in the pain, but they just have very uncontrolled pain, and we just don't act our best when our pain is uncontrolled. Is it not a kind of pain that's going to be responsive to opiates? A lot of neuropathic pains don't respond great to opiates. So that's just a fact. So maybe it's not the right kind of medicine. Addiction, diversion, something we always worry about. So just as an example, if you were trying to treat someone with acute pain, how it's recommended to be done. Say someone was on a 100 microgram fentanyl patch, taking about 4 or 5 hydromorphone a day, so 20 milligrams, and we wanted to treat their acute pain. This is what people would recommend. Figure out what their oral morphine equivalent is. This is how that would work, right? You'd say that 100 microgram patch is about the same as 240 milligrams of morphine a day. The hydromorphone is about the same as about 70, 80 milligrams a day of morphine. We add that all up and we say they're taking about 300 plus milligrams of an oral morphine equivalent, right? So in this math, you kind of have to do to juggle the meds. So if we were trying to change them to a different drug, we would drop to something that's the equivalent of 25% less than that. If we're treating acute pain, we start saying we want to give about 10 to 15%. Some people say 5 to 10, 10 to 15 somewhere, if you just have about 10% in your head, that's not bad. The total daily dose is the acute dose for someone in pain. So if they were on 300 milligrams of morphine a day, the dose of morphine we're going to give them now for acute pain on top of that is going to be 30 to 45 milligrams for the acute pain episode. Otherwise, the 5 milligrams of oxycodone, the hydrocodone 5 milligram tablet, it's just not enough medicine in the face of that much opiate to treat pain. That's treating us. We gave them an opiate. We did the right thing, but we didn't treat their acute pain, and that's not what we should be trying to do. So if uncontrolled, people will increase it from there if they tolerate the drug, but just as a starting point, when you're seeing that person, acute pain exacerbation on lots of opiates, this is how the recommendations are to treat their pain. And I haven't done this a ton. Luckily, that doesn't happen a ton. You sort of get around it, but it gives you some kind of direction. So there are side effects. Interesting enough, the opiate side effects tend to get better when you're on the medicines for all. With dose changes, initiation, you see it. Probably the constipation is the one thing that kind of hangs around for most folks. So if someone's really having lots of constipation, there are some things we can do. Almost everyone would say, and it's not great science to it, that if you're going to be starting someone on opiates, you probably want to start them on an opiate, on a laxative regimen. Docusate 100 twice a day, maybe 200 twice a day, maybe a center or two at night, maybe Miralax. You could do whatever you want. There's no data to tell you what's right, but actually do that out in front of it. If someone stays constipated, traditionally we've had methylnaltrexone. I won't say I've used that much before. That's a sub-Q drug given every other day for opiate. That's been the standard of care for profound opiate-induced constipation, particularly in cancer patients. There is a new drug, naloxegol, that's out. That's actually FDA approved for non-cancer opiate-related constipation. That is an oral pill. Has a relatively low side effect profile. I have not tried that drug yet. I'm actually toying around with trying it next week for the first time. It does not cause exacerbations of pain. It's a peripheral mu receptor antagonist, so it does not make pain get worse. That's clear. A big New England Journal trial looking at it. So it hasn't been approved for use in cancer pain, but I think it's likely to become the thing that people start trying relatively soon. And I think, like I say, the CNS stuff tends to get better until we get to these mega doses, and people have wondered about things like methylphenidate to clear the head. Okay, just a few more things and we'll be done. I think if pain medicine doesn't work, that's okay. You're kind of bummed. I always say, hey, I wish this had been helpful. Like, not every doc would have started you on opiates. I was willing to try doing that. Probably a little less of an issue in the cancer pain population, but in the general population. And we're going to still try to do what we can. We tried pretty hard. When should you give up on opiates being helpful? So does anyone have like a morphine number? I'm done. I stopped there. It hasn't helped. I'm stopping. So if you don't, if you're getting into the 100 to 120 milligram oral morphine equivalent a day and you've not seen benefit, I wouldn't go higher than that. If you lived in Washington State, if you did that, you'd have to send them to somebody else who would say they actually should be on that much medicine, because that's where you start seeing a huge spike in the problems with the drugs. It's in the 100-plus morphine equivalent. Now, I mentioned that in the trials of looking at morphine in cancer pain, patients were often on 100 to 250 milligrams of morphine, and that's fine. If you get to 100 and they've had a lot of benefit and are inadequately treated, it's fine to keep going forward on that. But if you get to 100 to 120 and you've not seen much that you live on, that's a therapeutic trial to me. And I think we shouldn't be pushing past that. And most people are going to be like, that's who they're looking at, right? Because that's when you see the spike. It's not the 20 milligrams of oxycodone a day that's getting people's attention, right? It's the 83 times a day of oxycodone extended release. That's what's getting people's attention. Why are you doing that? What is the necessity? And show me that that's the right thing to do for this patient. But if you're going to stop, and they've done nothing wrong, I do 10% per week. I've done this a bunch of times. It takes 2.5 months to get them all the way off the drug. You've got to do a little bit of finagling with the milligram dosing when you get lower, and just work your way down. If someone has, these are the reasons people would put down, you should consider abruptly discontinuing. Probably not as relevant in the cancer population as I mentioned, but if you're starting to find people alter prescriptions, they've had clear negative effects like overdosing intentionally on the medicine or accidentally. They threaten, they've been found selling the medicines. And people, this is a struggle, right? This is no different than trying to take someone who's taking heroin and stopping heroin and going through the miserableness of that. You can try clonidine, you can try, people have these high-dose tramadol. I'm not sure that love that either. And you just support them through it. So last 2 slides, just to remind ourselves, we're going to try to avoid using high doses of oral morphine equivalents if we can't do it. We're going to be sure there's been benefits. I think we need to be careful about methadone, realize that fentanyl has a few other little risks in it, like the things like not having fat or in the MRI scanner. Be careful how you switch around when you're going from one thing to the other. That risk assessment tools, I think we all got to figure out how we're going to incorporate those into our practice, because they're kind of being pushed on us before we're really ready to use them, I think. And just to remind us of the things I've tried to cover along the way.